Fellowship training in Hematology, Oncology, again here at Jackson. Dr. Hosein was an assistant professor here at UM before taking a position at the University of Kentucky for 2 years, and this past September he returned to the University of Miami now as an associate professor. He has been the principal investigator for multiple phase 1 and 2 clinical trials for patients with liver and pancreatic cancers conducted at the Sylvester Comprehensive Cancer Center, and participated as a co-investigator in national phase 3 clinical trials in pancreatic and colorectal cancer. His primary research is on a neoadjuvant therapy for patients with localized pancreatic cancer. So please join me in welcoming Dr. Hosein. Thank you very much.
Thank you. Thank you very much for having me today. It's a pleasure to be here. I was away, as Andrew said, for a brief period of time, and I'm very happy to be back. So today I'm going to talk about something which is not my primary interest and primary research, but it's something that I've done some work on. And the speaker for today canceled, so they asked me if I had anything prepared to talk on, and I had a slide set prepared on this already. So the topic is on comprehensive genomic profiling. And for those of you who are not oncologists, I'm going to try my best to introduce you to the concept and let you know where we are today. So my objectives that I will try to achieve in the next 45 minutes or so is to describe the concept of comprehensive genomic profiling for identification of clinically relevant genomic alterations. And I'm going to look at the institutional experience, not at the University of Miami, but at my former institution where I did all this work, and review some of the published data and talk about some ongoing trials of what we refer to as genomically matched therapy. So this is an excerpt from the State of the Union address in 2015. President Obama said that he wanted a country that eliminated polio and mapped the human genome to lead an era of medicine, one that delivers the right treatment at the right time. In some patients with cystic fibrosis, this approach has reversed a disease once thought to be unstoppable. For those of you who treat cystic fibrosis, you might disagree with that. But he said that he's launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give us all access to the personalized information we need to keep ourselves and our families healthier. So it's not accidental that he mentioned cancer, because this is a disease where personalized medicine, I think, has reached the furthest among all the specialties of medicine. So what is precision medicine? Precision medicine has been around for a long time. People never referred to it as precision medicine before, but if you have a 75-year-old patient with pancreas cancer and a 45-year-old patient with pancreas cancer, you would obviously treat those patients differently. So we already personalize treatment based on clinical factors, but what precision medicine is referring to is classifying patients now based on new markers that we didn't know about before, specifically genetic markers. And I'm going to talk a little bit about some of those tools that we have. So medicine has always been personalized or individualized, but precision medicine is really talking about new ways of characterizing the disease and new therapies based on these new subtypes that we are creating for the diseases. So this algorithm or flow chart was taken from a paper in the New England Journal of Medicine last year, talking about the paradigm of how we apply precision medicine. So if you have a heterogeneous disease, for example, we have a number of breast oncologists in the room. The subclassification of breast cancer by genomic subtypes was the first cancer to have that done. That was actually around the year 2000 when that was published. And compare that to pancreas cancer, that was only done about 25 years later. So you take a heterogeneous disease, and you have diagnostic testing that can subclassify the disease now into new subtypes. So previously, for breast cancer, you would look at hormone receptor positive versus hormone receptor negative. Now we have HER2 positive breast cancer. They now refer to the ER positive ones as luminal subtype. So we're now subtyping the patients more accurately, I would say, and you can plan treatment better. And then based on subtypes, you can now understand the biology a little bit better and try to design treatments which are more specific to these subtypes. And if you have treatments that you think would work for a subtype, then you embark upon clinical research, and then those can change the guidelines. And the best example in the modern era of this probably is the story of HER2 targeted therapy in breast cancer, where a subtype was identified, a treatment was developed, tested, proven to be effective, and now is incorporated into routine clinical practice. So this process takes a long time, takes a lot of science, takes a lot of patience, a lot of money to bring something which is a new subclassification, a new treatment to practice. So precision medicine oncology is not new. People have described androgen dependence in prostate cancer for a long time, folate antagonists in leukemias, anti-estrogens in breast cancer, and you go down the list. This was taken from a review by John Mendelsohn, who was one of the pioneers of the modern era of targeted therapy. He's the one who really developed the cetuximab monoclonal antibody against the EGFR, receptor. And you have a number of examples there. HER2, BCR-ABL for CML. Other examples of diseases which were really difficult to treat before. For example, CML patients would survive for months to years, and now these patients are surviving decades with BCR-ABL inhibitors. So what is the change that has taken place now because of precision oncology? Well, traditionally, you would have a disease subtype or a disease type. So if you have a colon cancer patient who is stage 2 or stage 3, you would choose the chemotherapy based on the stage. So if you have stage 4 colon cancer, you have a long menu of options. And if you pull up the NCCN guidelines, there's so many different options based on the stage of the cancer and based on the histology of the cancer or the primary site. Now we have treatments which are really sort of agnostic to the site of the primary tumor, but determined based on a molecular alteration. So now we have HER2 targeted treatment, which is approved not only for breast cancer, but for gastric cancer, and we've seen patients with other types of cancer where they have HER2 amplifications benefit from trastuzumab. So in some respects, the precision medicine paradigm is tissue agnostic, but we know that is not exclusive because, for example, about half of patients with melanoma have a BRAF mutation, and they respond very well to BRAF inhibitors. But the same BRAF mutation, if it happens in colon cancer, if you give the same treatment, it doesn't work. So the site of primary origin of the cancer also has a role to play, but now there's studies which are no longer targeting one cancer type, but is targeting one molecular alteration. I'm going to talk a little bit about that. So the tools of the trade in precision medicine or precision oncology have been evolving very rapidly. So the EGFR activating mutations in lung cancer they were really only described about 12 years ago, maybe a little bit longer than that. And the therapies which are now approved based on that biomarker are recent. And it's not too long ago that people initially reported sensitivity of BRCA mutant breast cancers to PARP inhibitors. Those are still, that story is still being worked out. And there are a number of examples along the way. And one thing which has made a big difference is the Cancer Genome Atlas, which has really characterized cancers. And now as of 2016, more than 10,000 tumors profiled by the Cancer Genome Atlas group. And now almost every cancer type is being subclassified based on these genomic classifications. So now, recently in pancreas cancer, there was a description of 4 different molecular subtypes of pancreas cancer. So far, that is not important clinically because we don't have treatments for those subtypes, but this is now being described in almost every cancer where we can subclassify diseases based on biology and etiology and try to get better treatments for them. So this is already in clinical use routinely. FDA-approved treatments based on molecular alterations, and these are some examples. These are not all the examples that we have in oncology, but we already mentioned ER/PR expression, which is usually tested by immunohistochemistry for anti-estrogen treatment, HER2 amplification, usually by in situ hybridization for trastuzumab, EGFR activating mutations predict for sensitivity of alatinib, etc. So these are various markers that are already in practice. So, for example, when I see a new patient with colon cancer, I have to know what is the KRAS mutation status, the BRAF mutation status, the NRAS mutation status, and whether that tumor is microsatellite stable or unstable, because the treatment algorithms are based on those molecular markers. All right, and it's no longer, initially cetuximab was developed for EGFR positive by immunohistochemistry, and now we don't do that. We have to have the molecular information in order to determine the treatment. And for example, in lung cancer, we know that frontline treatment with a targeted agent against an EGFR mutation is much superior to chemotherapy in the frontline if the patient has an activating mutation. So to decide on frontline treatment, we really need these tests. And we now have the capacity to do these testing very quickly, and most of these tests are done in-house. So by the time the patient comes to see us, we have those results, and we can use it to make treatment decisions. So how is that now incorporated into practice? So previously, if you go back 20 years, you had a menu of chemotherapy options. And for example, metastatic colon cancer, you would use one chemotherapy option in the front line. If the patient has disease progression, you switch to a second line of chemotherapy. And that's based on clinical progression. Now, with the precision medicine algorithm, if you have an advanced cancer, you test for a biomarker. And an example of this is lung cancer. If you have an EGFR activating mutation in lung cancer, the frontline treatment is usually erlotinib or gefitinib. And there's another one, afatinib, which is also approved. But with these targeted agents, it's very common to develop resistance. And one resistance mutation in lung cancer is referred to as a T790M mutation. And if that mutation develops, those tumors develop resistance to the targeted agent. And now there's an FDA-approved agent called Tagrisso. The generic name is osimertinib, which was designed to target that mutation. And similarly, in CML, there's development of a T359 mutation in patients with CML, and ponatinib was a drug which was developed for that mutation. So now we have patients who undergo frontline treatment, and then at the time of progression, you many times have to repeat the molecular analysis to see if you have resistance mutations developing. So that's why sometimes oncologists ask for repeat biopsies at the time of disease progression, because you want to know what the molecular alterations are occurring at this time, because we know that cancers are heterogeneous, both spatially in the same patient and temporally in the same patient. So that's a rationale for doing repeat biopsies nowadays. So we know that there are molecular markers which are already incorporated into standard practice. So what happens when we run out of standard options? And that's going to be the focus of my talk today. So we have many patients, not necessarily with pancreas cancer, but with breast cancer and colon cancer, who have gone through all the standard lines of treatment, and they still come to the office walking in looking like nothing happened to them. They might be a little bit worn down from getting chemotherapy, but these are patients who still have good performance status, and you look down the list of options and you ran through all the list of options and there's nothing left. So what do you do for a patient like that? The patient is saying, well, I'm 35 years old, I have an advanced cancer, you don't have anything else to offer. So this is where we normally look for a clinical trial. And now clinical trials are, in general, being designed for subtypes of molecular alterations. And sometimes these are referred to as actionable mutations. And actionable mutations can mean different things to different people. I'll explain to you what are real actionable mutations versus theoretical ones, which are probably not validated yet. So how do we discover actionable mutations? There are a number of different technologies that we have available. You can look for protein expression by immunohistochemistry, and I put this up not to advertise for this company, but just to show you that you can send a tumor out to this particular company, and they will run all these various platforms and all these tests, and they will send a report back to you saying that the ALK is not translocated, saying that PD-L1 is overexpressed by immunohistochemistry. They can tell you if the EGFR mutation is present. They can tell you if the MGMT is hypermethylated or hypomethylated, and then suggest to you what are treatment options based on these alterations. So actually, in my opinion, for this particular test, there isn't too much value in this one, but patients can access these tests, actually request it, and they come to you sometimes for a second opinion with these results in hand. and they say, okay, this molecular test said that we should use drug X, Y, or Z. What do you think about that? And then many times it's not really validated, but these people have to sell their technology, so they do that. And then the most, I would say, the most sophisticated form of discovery for alterations is next-generation sequencing. And these people do it based on a 592 gene list of genes which are important in various cancers. And there are different companies. For example, this one is a company called Foundation Medicine that has a gene list which is ever expanding. They have, right now, I believe they have more than 500 genes that you can send a tumor biopsy. You take a core biopsy of a liver mass, a very small piece of tumor, send it to them. They will extract the DNA and do sequencing on these genes of relevance. And they, in addition to doing next-generation sequencing, they do different techniques to look for translocations, etc. And then they generate a clinical report. So the turnaround time on this test is actually not months, which would have been the case 10 years ago. The turnaround time on this test is actually 2 weeks. When you send this, from the time they get the sample, you get the result back in about 2 weeks. And most of that 2-week period is spent on analyzing the results, because the machine spits out the result or the raw data within the first 24 hours after they process it. And the rest of the time they sit down there kind of figuring out what to do with the results and how to interpret them. So this is something which is commercially available, this particular test, the Foundation 1 test. And this data that I'm showing on this slide was actually obtained from their financial disclosures at the end of the year. The test became commercially available in 2012. And this axis here is labeled in thousands. So in 2012, they did less than 2,000 cases. And then in 2013, 8,000, 2014, 22,000, 2015, that's about 33,000. And they are projected to do 40,000 tests in the year 2016. This is a commercially available platform for next-generation sequencing of tumors. So if they're doing 40,000 of these tests, and this is just one vendor, there are many of these tests out there. So what do we do with these results? All right, and that's what I'm going to try to decipher. So how did I get involved with this? Well, this test became available in 2012, and of course we see patients at this center who come for second opinions. Many of them want to know what is out there, what is outside of the box. So most of the oncologists in our faculty do this type of testing. So I started this. This was one of the first patients that I profiled. And this was a 64-year-old lady who had a retroperitoneal tumor of unknown primary. And she had a prior history of breast cancer, but they did a lot of testing, and they figured out that it probably is not breast cancer because it looks different. All the markers were different. So she ended up with me because nobody else wanted to treat her. So I sent this test out, the Foundation 1 test, and these were the results that came back. Now, in the Cancer Genome Atlas, in most of the cancers that were profiled in the Cancer Genome Atlas, the average number of mutations could run from 60 to 100. In pancreas cancer, for example, the average is about 60. But what they do is they pull out the alterations from their list, which they think are clinically relevant. So these are the ones that they report, and then if they find other alterations which they don't know what to do with, they call them variants of undetermined significance. So that's reported separately. And then they have a whole team of people that look at these alterations. They search PubMed on a daily basis and see if there's anything new coming out for any of these things. And they have a database of clinical trials that they can match up with to see if you can treat any of these alterations with any type of targeted treatment. So for any oncologist in the room, you will know that TP53 is a tumor suppressor gene which has been traditionally felt to be undruggable. Right now, there are many clinical trials which are looking at different ways of trying to reactivate P53 and using that. But so far, this has been a very difficult target to try to drug. But there are clinical trials listed there as possible options. And then a number of other options, a number of other alterations. So when I got this report, I actually sat down it took me about 3 or 4 hours to go through each one of these and try to figure out in my mind which one I think is the most scientifically relevant and which is a trial that might be the best trial for this patient. And you have to also take into account whether the patient can travel. This patient had means to travel, so she ended up getting referred to Boston for a clinical trial of an MCL or cell cycle inhibitor. based on the MCL1 amplification. So this was one of the second study, I believe, is a study that she was enrolled in. And at that time, she had been through 3 different lines of cytotoxic chemotherapy, and she was treated on a clinical trial with a cell cycle inhibitor based on the MCL1 amplification, because this is a protein which supposedly increases cycling through the cell cycle, and if you try to shut that down, you might shut down the cell. So she had no benefit at all from that clinical trial. She was put on a treatment, and the first scan was supposed to be done after 2 months, and when she had the scan, she had disease progression. So she came off the study. So obviously she was disappointed, I was disappointed. So we didn't really have anywhere else to go with her. Eventually she progressed and died. The next one that I profiled, we found a very common mutation. KRAS is mutated in about half of colon cancer patients, of metastatic colon cancer patients. But there was an interesting alteration found in a gene called STK11. And for those of you who are not molecular biologists, I put these very nice diagrams that you can get from cell signaling website, where you have a nice, very neat pathway that shows you a cell surface growth factor receptor that activates downstream different proteins. And STK11 is a protein which is a negative regulator of this system in the cell called mTOR. And mTOR is something that regulates transcription and eventually cellular growth and proliferation. So if STK11 is a negative regulator of this pathway, and STK11 is silenced by a mutation, then the pathway might be overactive. So theoretically, if you have a mutation in STK11 which inhibits its function, then mTOR might be upregulated, and if you use an mTOR inhibitor, that might be a potential treatment option. And in fact, this recommendation by the company who sent me this report of using these drugs, everolimus is an mTOR inhibitor, temsirolimus is an mTOR inhibitor. These 2 drugs are what we refer to as dirty kinase inhibitors. They inhibit a number of different tyrosine kinases. So those were also drugs which they thought could be effective. And that was based on the theory of how the pathways work, in addition to one case report. So there's a case report published of a patient with a pancreatic neuroendocrine tumor. That patient was sequenced, or the tumor was sequenced, and there was an STK11 mutation. That patient was treated with an mTOR inhibitor and had a response, and they published that. So based on that one publication, plus the preclinical evidence, this recommendation shows up on this report. So in the absence of any other options for this patient, we tried to get an mTOR inhibitor for him. The oral drug everolimus was not approved by his insurance. We were able to get temsirolimus approved. He got treatment for 1 month, clinically progressed, radiographically progressed, and eventually died. So again, second patient profiled, no benefit. Next case, young lady with metastatic colon cancer again a KRAS mutation. So this time I decided to, let's focus on the KRAS mutation. It's a very common mutation in colon cancer. And in lung cancer, it's also mutated very commonly. In pancreas cancer, almost 90% of patients have KRAS mutations. So why would you recommend a drug like trametinib? Well, again, you go back to this very neat system of trying to understand the pathway. So KRAS is downstream of many cell surface receptors or growth factor receptors. And if you have a RAS mutation, these usually activate the system downstream. So if you use an inhibitor of this protein, MEK, which trametinib is a MEK inhibitor, then you may be able to shut down the system. Now, what this nice, neat diagram doesn't show you is that there are 1,500 other pathways that talk to this pathway. So if you shut down MEK in this system here, if you have a very clean MEK inhibitor and you shut that down, then there's something called homeostasis. The body adapts, the cancer cells adapt, and there's something else that gets upregulated that bypasses this little protein, or the one protein that you decided to shut down. And that actually is the reason why MEK inhibitors do not work. People have tested MEK inhibitors in lung cancer in an unselected way. In monotherapy studies, they don't work. In pancreas cancer, it doesn't work. So they decided to recommend trametinib just based on that theoretical possibility. There's no study that ever used a MEK inhibitor in colon cancer that I could find that showed any benefit. And we tried to get trametinib for this patient. It was not approved by the insurance. So that was the end of the story for her. And in fact, I spoke to the company, and they said, well, we have no clinical evidence that trametinib is beneficial in KRAS mutated colon cancer, so we're not going to give it to you anyway. And then finally, this was recently in my previous institution, where I was actually dabbling a little bit in sarcomas. This was a young lady, 23 years old, with an unresectable sacral osteosarcoma, initially localized. She received chemotherapy. The plan was to try to do radiation. She progressed with lung metastasis, and we profiled her. So there were two alterations here, CCND3 and CDK4. Both of them are alterations which affect the cell cycle. So potentially, if you have a cell cycle inhibitor, that could help because they recommend the same drug for both alterations. So surprisingly, this patient was a Medicaid patient, and Medicaid approved the use of palbociclib in this patient off-label. And we gave it to her. She had absolutely no benefit. She continued to progress clinically, and after 2 months, she had a scan which showed significant disease progression. So now I've given you 4 cases, anecdotal experience. 3 of them were treated with targeted treatment based on this result. 1 of them, I couldn't get the drug, and so far, nobody benefited. So based on this, I started asking, well, what are we doing, right? Is this something that makes sense? Should I be sending this test out to this company or any company to figure out if this patient has an alteration, and what should we do about that? So this is the question that we came up with to try to initiate this study. So the study was a retrospective study done at the University of Kentucky. That's a cancer center which is not as big as ours, NCI designated, and a fairly decent volume of patients. So we looked at all the patients who had any type of genomic profiling from 2012 to 2016, and the Foundation One results were the easiest to find because you can get all of those electronically. You just log into the website and you can get all of them. The rest of them were kind of paper-based, so they were a little more difficult to track. So we focused really because the Foundation One test was the most common test that we had sent out. So that's the one that we focused on. And in that series, we profiled 171 patients in that time frame. And you can see that the uptake of this had been increasing. So if you project out from March 2016, 44 cases, that would give you probably about 120 or 130 cases. So exponential increase in the number of cases that were sent out for profiling over that 5-year period. So these were the patients that we included in the analysis set. We defined the analysis set as the patients that we had follow-up information on based on the results of the genomic profiling. So 107 adult patients, 19 pediatric patients, a wide range of different types of cancer. Most of the GI patients were my patients who we profiled. I was seeing adrenal cancers there, a few sarcomas as well. So a group of refractory cancers mostly, prior lines of systemic treatment. More than half of the patients had at least 2 prior lines of systemic treatment. And some of them had on-label targeted treatments as well. For example, there were some patients who had HER2-positive breast cancer who received trastuzumab and then were profiled and went on to receive some other form of treatment based on profiling. So I showed you what the sample report looks like. This is what we found. Valid results mean that they were able to extract DNA. Sometimes you send the specimen and there's not enough tumor to extract DNA. So most of the patients we were able to get valid results from. And the test recommended on-label options for 25 patients, or 24%, off-label options for 74% of the adult patients, and clinical trial options for most of the patients. And these are the usual suspects. If you do any profiling study, these are the kind of pathways that are usually involved. The PI3K pathway, again, the first 2 are involved with signaling from growth factor receptors on the cell surface, and a variety of different pathways involved. So out of these 126 patients, 15 of those patients ended up having treatment directed based on the results. And I highlighted 3 lines there with the 3 patients who seem to have some benefit from this approach. So on the last column, best response after genomically directed treatment, PD means progressive disease, SD means stable disease, and in oncology, if you achieve stable disease in a patient like this, that's considered to be a favorable result because most of these patients were progressing on their prior lines of treatment. So if you stabilize their disease with the current treatment, you think that that might be something due to the treatment that you're giving the patient. So the first example was a lung cancer patient with a RAS mutation who was treated with a MEK inhibitor. That patient had disease stabilization for 5 months. There was a pediatric brain tumor patient that had a BRAF mutation treated with a BRAF inhibitor, had disease stabilization for 6 months, and a gastric cancer patient who was HER2 amplified, had a FLT3 amplification as well. I think that might be mutation, but sorafenib is a weak FLT3 inhibitor, and that patient had stable disease on the first imaging assessment. So why did the rest of patients not receive genomically directed treatment? There were some of them that had no actionable mutations, some of them who were on surveillance, and we had sent this, expecting that they would probably recur at some point in time, so we didn't have the opportunity to act on the results yet. Some patients were still receiving standard of care options, and some patients, for example, adrenal cancer patients, sarcoma patients, they run out of options very quickly. So sometimes what I do in my practice is send the profiling during the frontline treatment. So when you get to second or third line and you don't have anything else, you have these results that you might be able to act on. So some of these patients were still receiving standard treatment by the time we got the report, so we didn't use it. But the biggest, one of the biggest reasons is that we didn't have any clinical trial options available. And then some patients just were profiled too late in the disease course, so by the time you got the results, their performance status had declined, and you don't have the opportunity to give them any type of treatment. So if you look at the overall outcome of this study, out of the 126 patients who were profiled, that is the denominator. The report said that there were 91% of them with actionable mutations, and some of them you can debate whether they are really actionable or not, but that's what the report said. 12% received genomically directed treatment, and if you use the criteria that we used for stable disease being a form of benefit, then only 2% of patients had any benefit from doing this. So if you do the math, this test cost $6,000. We did it 126 patients. That's a lot of money to help 3 patients, right? But how much does it cost for 6 months of life? That's a rhetorical question. So, that's something that is always has to be considered when you're doing testing. What is the benefit of the testing? So potential benefits, apart from having 3 patients who had disease stabilization, there were some alterations that were reported that were not only of therapeutic significance, but also of diagnostic significance. So there was one patient that was actually referred to me, and they told me that the patient had Ewing sarcoma of the bladder, which is very uncommon. So we sent profiling on that patient, and it turned out that patient did not have an EWSR1 translocation. So they reviewed it again, and they called it a small cell cancer of the bladder. So we changed the diagnosis based on this result. So it has some diagnostic value in some patients. And then in that center that I was at, in colon cancer patients, they would send out KRAS, the KRAS and the BRAF testing would be done in-house, but the NRAS testing had to be sent to a different lab, and MSI was done in a different place. So you had 4 different tests that you needed for clinical decision-making, but you had to split the tumor up and send it to different people. Whereas if you send a tumor to one lab, they can do all that in one shot. So that was one potential advantage. And then in terms of insurance coverage, the way that this test is set up is that they don't ask for prior authorization, but they look for reimbursement after the test is done. So that was potentially beneficial in some patients who we had insurance barriers. For example, BRAF testing is not covered in colon cancer by some insurance plans. So if we send this test, we could get the BRAF result out and kind of bypass the insurance barrier. So those were some sort of side benefits of doing the testing. These were not the reasons why we were doing it, but those are some of the benefits. What were the risks involved? Well, the main thing is that a lot of patients come to you saying, well, don't you have any individualized treatments for me? Don't you have any personalized treatments for me? Do you have any targeted treatments? And now everybody's asking for immunotherapy as well. And a lot of patients are sold on this hope that you're going to send this test out and you're going to get a result that's going to help them and it's going to be a home run treatment. And the truth is that we didn't see any home run treatments in our study. And I'm going to show you a number of different studies as well that also did not find really significant responses doing this. Now, I'm going to show you a study that said that the toxicities of off-label treatment might be actually worse than doing nothing. So if you have a patient with advanced cancer who has no other standard treatment options left, and you use some off-label option for that patient, the patient may have toxicity from that treatment, and the patient might have been better off receiving supportive care rather than getting a treatment that gave them toxicity. And I've seen it happen before where patients are insisting that they want treatment, and it probably shortened their lifespan by doing that rather than going with supportive care. And again, the cost of testing is not trivial. So I'm going to go through, hopefully I have time to cover all this. What is the evidence right now, apart from the small study that we conducted? Are there any other data that we can use to guide our practice? So these are the different types of studies that I'm going to go through. Anecdotal cases, I gave you a few of them already. I'm not going to go over any more. Retrospective case series, I showed you one. I'm going to show you a couple more. And then there's some prospective trial designs now, which are being implemented for genomically matched clinical trials. And then I'm going to show you one prospective randomized trial using genomically matched treatment. So Vanderbilt published their data, similar type of thing that what we did. They did their study about 2 years before ours. And basically, they looked at their experience at their center, looking at targeted next-gen sequencing. They also used the Foundation 1 panel. 103 patients. According to a report, 83% of them had potentially actionable mutations. 21% of the patients in that institution received genomically directed treatment. The number in our study was 12%. And among these patients, they actually did not report the proportion of patients who benefited from this approach. So among the 21% who received genomically directed treatment, they didn't tell us how those patients did. So the numbers are sort of similar to the numbers that we had. And this is another institutional series. I'm going backwards. Another institutional series published in the same journal in the same issue. This was from UCSD, who has they have a significant precision medicine program there. Their series was a lot smaller, 34 patients. They found 11 of their patients had treatment based on the sequencing result, and 3 of them achieved partial responses. So this is my note here. The rate of patients who received genomically directed treatment based on profiling was 32%, and the response rate, if you use 34 as a denominator, was 9%. So 9% of the patients going in derived some benefit from this treatment. Cornell has a significant experience as well. They have something called the Institute of Precision Medicine, IPM they call themselves. And their series of 97 patients, in that series, there was only 5 patients, or 5% of patients, who got treatment based on the next-gen results. And among those, they only reported in this paper 1 patient who had substantial benefit out of 100, so 1% in that study. Remember, the one I showed you from my experience was 2%. Now, on the other hand, you will see a few studies like this from MD Anderson and from Fred Hutchinson presented something recently at ASCO, where they looked at the response rate if you take patients who get into genomically matched clinical trials. So in the MD Anderson series, what they did was they had a program where they would profile patients coming through the door, and they did profiling on 1,200 patients. And among those patients, there were 116 plus 36, so a total of 175 plus 36, so a total of 211 patients who received genomically based treatment from their profiling program. And among them, they reported a response rate of 30%, 30%. So if you go back to the original denominator of 1,200, 4.4% of patients derived benefit from that approach. Now, if you look at the abstract, they will say that the response rate was 27% in patients who received genomically matched treatment versus 5% for patients who did not. But really, the denominator is not the number of patients who get matched treatments, but the number of patients who are eligible for this type of approach, who go in and start the sequencing program with the hope that I'm going to be the patient that has the mutation, that will have a study for, that will have the home run treatment. So if you take that as a denominator, then the actual number of patients who benefit is very small. And this number is consistent across most of the series that you find. So now going on to prospective studies, we have now what we refer to as basket trials, and then there are umbrella trials. I'm not going to get into too much details about this, but these are just various ways of doing studies which are agnostic to the tissue of origin or the site of origin. So bucket trials are taking patients with a specific mutation, regardless of where the mutation came from, if it was a lung cancer or if it was a colon cancer, and treating the patient with a specific targeted treatment against that drug, against that alteration. So this is a basket trial which was published by a thoracic oncologist who was on faculty here recently. And what they did here was they profiled a number of lung cancer patients, started with 647 patients, and put them into different groups or different pigeonholes, and treated them with different inhibitors. So this is an AKT inhibitor, which is an inhibitor of the mTOR system, or one of the proteins in the mTOR pathway. EGFR mutations treated with alatinib, RAS mutations treated with a MEK inhibitor, HER2 amplification treated with a HER2 antagonist, and KIT or PDGFR mutations treated with sunitinib, which is a kinase inhibitor against these. So they ended up with 15 different arms in this study: non-small cell lung cancer, small cell lung cancer, and thymic cancer. And you can see that the number of patients accrued to each of these little buckets were very small. And the conclusion in this study was that the basket trial design was not feasible for many of the arms with rare mutations. So when you try to do this in a systematic fashion, you have to screen a number of patients, a large number of patients, to get the alteration that you need to put the patient on the treatment. So if you have a group that ends up with 6 patients and you treat that patient or those 6 patients with a targeted treatment, that group of 6 will just have not enough power to tell you if that treatment is effective or not. And of course, there's no control group there, right? So this kind of design is good for seeing great responses, but you don't know if you would have achieved the same result by giving a MEK inhibitor or giving cisplatinum. You don't know. There's no control group. So umbrella trials are sort of similar. They just have a greater number of arms. You're testing multiple drugs in parallel based on different alterations. So the prototype umbrella trial is called the NCI Match Trial, which is open here at Sylvester. So this is a national cooperative group initiative to try to do this in a systematic way instead of every oncologist down the street sending their tumors out to Foundation 1 and doing their N of 1 trials. People are now trying to do this in a more systematic way. So the way that this is being done is patients with refractory cancers, you subject them to a new biopsy, you send the biopsy to the NIH, or I don't remember where's the central lab that is doing this. They do sequencing, they come back, there are 20 different options based on different alterations, and they put the patients into one of those options if they have one of those alterations. You treat the patient. The good thing about this is that the drugs are available on the trial, so you don't have to fight with the insurance. The drugs are provided through the study. And this study is accruing. They had issues with processing time for the results, because if you have a patient who has advanced cancer, it's very difficult to wait 4 weeks to get this result back, which is how long it was taking when they initiated the study. So this is something that is being refined as we speak. Now, this is the only randomized trial I'm going to talk to you about. And this is not a randomized phase 3 study. It's a randomized phase 2 study. And what they did in this study, this was a French study, 741 patients screened for molecular alterations in various pathways, including hormone receptor pathways, the mTOR pathway, the MAP kinase pathways, and you were able to choose one of these regimens based on whatever alteration you detected. So they ended up finding their alterations that they were looking for in 195 patients. They randomized these patients to receive either targeted treatment or investigator choice treatment, which means that they were not targeted treatment, but whatever chemotherapy the oncologist felt would have been appropriate for that patient. So if you had a patient with lung cancer who is now coming up to second-line treatment, and your preferred second-line treatment is pemetrexed, for example, then the oncologist could choose that, and then you would randomize those patients are now randomized, so you have a control arm of standard of care treatments, which are non-targeted versus targeted treatment. And this study had some very sobering results. There was no difference in progression-free survival among the two approaches. So if you use a targeted approach in this particular study, they did not improve survival compared to physician choice. Now, this study has been criticized because if you go back to the options, the argument here is that everolimus is not a strong mTOR inhibitor. Single agent anti-estrogen treatment in a patient with refractory breast cancer is unlikely to show you a lot of benefit, and so on, right? So you can punch holes in all these treatments. And the study was a small study, so possibly it would not have been powered to detect small differences within those subgroups. But at the end of the day, it is the first randomized trial that we have testing a standard approach, which is what we refer to as a traditional paradigm versus a new paradigm of precision medicine. So people who are involved in precision medicine are not detracted by this because there are a number of limitations to this study. But I want to let you know that this exists there as argument for people who are against this type of approach or saying that we are jumping the gun on doing this. So what is occurring now in Sylvester? I believe that we have Batty in the room. I don't know where she's right. So Batty Gordon and John Trent. Is John here? No. So they are the leaders of the Precision Medicine Initiative at the Sylvester Comprehensive Cancer Center, and this is something that had been initiated in 2015, and please chime in if I'm saying anything incorrectly. I can take absolutely no credit for this. I only started back here 6 weeks ago. They did a lot of work to put this together. So the goal here is to provide a research-driven, molecular and genetic-based treatment approach to target each individual's cancer, and to provide physicians within our network with access to clinical trials based on these results. So what is involved in the Precision Medicine Initiative? Well, there's a molecular tumor board which was initiated in May of 2016. And, this is a monthly tumor board where patients who've had profiling done can be discussed in that tumor board, and a number of specialists from different, from genetics, from oncology, pathology, everybody is there to try to weigh in on what alterations mean for this particular patient and to try to find clinical trials that would be appropriate for that patient. Then the institution received funding to conduct this trial called the DEPICT trial, and I wish John was here to talk a little more about this. We talked about the MATCH trial as well, and there's a different study called GRAIL, which I'll touch on briefly. And then within the DEPICT trial, there's the option of doing in vitro drug screening for chemosensitivity or targeted treatment sensitivity. So the NCI Match Trial, as I told you, has 20 arms, and it's basically 20 parallel phase 2 studies in one. The QUILT trial involves immunotherapy. I don't know too much about that. This is part of our Precision Medicine Initiative. The DEPICT study is basically, how I look at it, and you can correct me if I'm wrong, it's a prospective way of using the profiling results in a systematic fashion. So instead of each individual oncologist trying to decipher the report themselves, we have a group of people who have expertise in this area who will try to guide the oncologist and the patient into the best treatment option. So if the patient already has sequencing done, this can be taken to the tumor board. If not, biopsies can be conducted and again, subjected to screening or sequencing. And if mutations are present, then we can funnel the patients into one of these routes, either to put them into the NCI Match Trial, to put them into one of our own clinical trials, to find a study somewhere else for them, and the final option is to use off-label treatment. So this is already in progress. There have been 91 patients enrolled to date, and these are the numbers. There are a couple of patients who were put on the NCI Match Trial. The Precision Medicine Tumor Board recommended a clinical trial for about 12% of these patients, etc. So off-label therapy, as you can see, was a very small proportion of these patients. And these are the patients who have been discussed so far in the Precision Medicine Tumor Board. Few of them have off-label. I'm sorry, this actually is depicting the average recommendation per patient. So most of the patients are referred for external trials, and the second most common recommendation is for internal trials. So this is, again, I can't take any credit for this work. This took a lot of work by some very smart people, very dedicated to this. And the next step actually is to open a precision medicine clinic, which should happen hopefully within the next few months, where patients maybe on the outside who have profiling done and want to get some of our expertise can come into the institution and see one of our providers and get recommendations based on our collective expertise. So in conclusion, what we have learned from our personal experience and from what has been published is that genomic profiling consistently reveals genomic alterations which may be relevant to some patients. And in some series, they report as much as 90% of patients have what they refer to as actionable mutations. How many of those are really actionable is debatable, but at least there's something you can put the patient in a clinical trial and try to answer that question. So the main barrier is access to off-label drugs and clinical trials. The NCI Match Trial and other similar trials can potentially remove that barrier. And as I showed you, there are 40,000 tests run by this one company every year in the US, and it's in routine clinical use. There are many patients who come for second opinions and they have that report in their hands. So it's, in general, it's not being done systematically. And I think the way that it's being approached at the Cancer Center here is the best way to do it, where you do it systematically, prospectively, so that you don't have these N of 1 series that will never be able to answer any questions, but at least you will have some strength in numbers prospectively to try to answer the question of whether this is a valuable approach or not. So I'll stop there and I'll be very happy to answer any questions. Yeah.
Had different type of expression of all these markers. When you do the molecular marking, do you take the whole entire tumor and mark and look at all the cells and see if all of them share the same mutations? Or you just take a piece of them? Is this a focal mutation or is diffuse?
Right. So that's an excellent question, and that raises one of the biggest difficulties in profiling patients. So there was a study published in the New England Journal of Medicine about 4 years ago, where the title was Intratumoral Heterogeneity in Kidney Cancer. And what they did in that study was biopsy a series of about 8 or 9 kidney cancer patients, the same patient biopsy different locations in the same tumor and in metastatic sites. And what they found was genomic evolution in the tumors. So there were different changes that happened in the primary site, in different locations in the primary site, and in the metastatic sites. So there's no way we can account for that, right? In a real patient in front of you, you cannot do 15 biopsies on the patient, right? Most times it's very difficult to do 1 biopsy on the patient. So how do you get around that? Well, there's really no good way of doing it. But what we do in practice right now, and what Foundation does, and what we do when we sequence patients, is that the pathologist looks at the tumor under the microscope, looks for the area with the most tumor, and they do laser capture microdissection to try to get the area which has the most tumor on the slide, and then sequence that area. But of course, if you sequence different areas from the same patient, it's likely that you might have slightly different results. And we know that if you biopsy the same patient over time, there are changes that evolve over time. So that is something that is very difficult to get around. I think he was, yeah.
Yeah, I mean, like oncologists have been very disappointed by these kind of results. And I guess the question I have is, what are we doing to, in terms of understanding why this is the case? mostly what we have is a lot of hand-waving explanations, some of which are very rational and well considered, but through heterogeneity and drug pumps and we're treating patients too late and all sorts of things, but no one has really determined why. So I guess the question is, to what extent is answering that question being built into the trials moving forward? I think we know, we can safely assume that all these trials that are ongoing, even the ones being designed now, the vast majority of patients will not respond.
Right.
So the question, the opportunity then is to answer the question why.
Right. So, and I can tell you about pancreas cancer. That's the area that I focus on. So there are a number of initiatives in pancreas cancer to take fresh biopsies from patients and to grow them in 3D culture or to grow them in mice ex vivo and try to understand why resistance develops, why some tumors are sensitive to some drugs and not sensitive to other drugs. So this is done in parallel with treating the patient. So if you do a biopsy for clinical reasons and you're trying to find the best treatment for that patient, there are some protocols now available where they're taking some of that tumor and doing ex vivo, what we refer to as patient-derived xenografts, or even in 3D culture. There are techniques developed for that now. So this is not widespread. I don't know. I assume that somebody on the campus might be working on that here. I don't know. I've just been back a few weeks now. But there are groups across the country who are working on things like that. And obviously that's a way to go to try to figure out. One of the,
I'll just add is that
yeah.
when patients don't respond to all the drugs, which most don't, the reason may already be there and the studies have already done. We need not look at the
Right.
treatment sample, but that original one should be there somewhere.
So Greg had a question in the background.
It's along those lines. We know that heterogeneous tumors, like when you sequence, you get all the mutations. So I was wondering if any of the biopsy of these patients who are the failures to look along what he's asking, have you now changed the mutations and selected for cells that are not sensitive?
Right. So I kind of ran quickly through the NCI Match Trial, but there is a part of that trial which is rebiopsying patients on progression. And the same people who analyze the original specimen will be analyzing the subsequent specimens to try to answer that question. But we know in lung cancer that there's acquired resistance mutations for EGFR tyrosine kinase inhibitors, for example. And in CML and a number of different malignancies, there are acquired mutations. And, this study is trying to do that systematically.
Doesn't it beg the question that using one inhibitor, knowing if you're heterogeneous number of mutations, that 2 or 3 actually might be effective?
Right. And yeah, so you hear that argument a lot from people who don't see patients. It's very difficult to give a patient one targeted treatment, far less for 2 or 3. So that's, of course, if you have a resistance pathway that is upregulated when you block a certain system, then you should probably try to block both at the same time. And that is actually in practice right now in melanoma. You combine a BRAF inhibitor with a MEK inhibitor because one of the escape mechanisms is upregulation of that pathway. So if you shut down both at the same time, you get longer survival. All right, but that is one of the few examples in oncology where you have dual inhibition of a pathway that is successful and is tolerable in a patient. It's not so easy to do in real patients.
This is the last question, Jeff.
So, I think there are 2 major issues here. One, you see a lot of mutations, and we have a very poor understanding of what mutations are driving mutations. So in CML, there seems to be a very clear driver, targeted. But similarly, for a lot of mutations, a lot of malignancies where the mutations in BRAF, right, and targeting that single entity is useful. So I think it's important to begin to do these studies and correlate gene expression data with mutation data, and begin to try and discern which pathways are clearly switched on, and then go back and look at the mutations to see which mutations might be responsible for that.
Right, and
That's not been done. So what we're seeing is the weakness of sequencing alone.
Right. Right, no, but there are groups that do that. There's a big proteomic group at MD Anderson that is looking at pathways instead of single alterations. So they look at activation of the entire pathway, and there's a signature to look at protein expression or mRNA expression for PI3K, AKT, mTOR, TSC2, all the players in that pathway, and they come up with a signature to tell you if that pathway is upregulated or not, rather than if you have one single PI3K mutation or one single AKT mutation. So there are people who are working on that, but it's not easy because to do that, you need fresh tissue. Right? It's not, you can't do that from archival tissue.
So how would you decide which treatment to give? You have multiple mutations, but how do you
So that's the utility of the tumor board. And we know from experience that some mutations are just not easy to drug. And, based on collective experience in the individual oncologists and the tumor board, we try to come up with what we think is the best one scientifically for the patient.
Thank you, Peter.
The other thing, Peter, is you can make analogies from one tumor to another. If you identify mutations that in an unusual setting, and there is a pathway for which the targeting has been very successful in another setting, go back to the liver, and trying that inhibition in that setting makes a lot more sense. But it doesn't always work.
All right. Thank you, everybody. Thank you, Peter. Welcome back. It's an interesting and thought-provoking topic. It's very complicated. It's a lot of expense. I understand the need to spend in the
Good to have you back, Peter.